Hello and a very good evening to all of you who are watching us yet again today. And today, our topic is something that I think is the mood of the moment. We are talking about confusions and clarifications with one of the most eminent speakers on the topic of COVID 19. And we are going to cover everything from testing to vaccines to treatments to even symptoms and possibly what's right ahead of us in the future. As dentists, are we safe to practice with aerosols or not? And this is something that we have been covering with many experts. But today we have somebody who has written so much about this topic that he has gained the reputation to be a one man authority on COVID 19, I would believe. And I'm really excited to introduce this person. He is someone who I have admired for a long time, but during the lockdown, my respect for him has just maxed out. The amount of work, the amount of research that he's been able to produce to help the entire fraternity is phenomenal. I think single handedly, he has carried forward the baton for dentistry in times of the pandemic. From his consistent articles in Dental Tribune to numerous webinars, he has given us a wealth of information to learn from and empower us to get back to work. Just a few days ago, I saw him write a riveting letter to the health ministry, providing not only the fact that he is doing all this research, but also proving that he's an action taker for immense change for our entire community. The man is far beyond the few lines on his CV, but let me tell you about some of his accomplishments, as I'm sure it'll inspire each and every one of you who is watching there. Dr. Rajeev Chitguppi did his master's in periodontology from GDC Mumbai. He went on to become an independent researcher in dentistry. He is an educator in periodontics as well as implantology. I'm sure we've heard of so many lectures that he's done before. But he is also the executive editor of Dental Tribune South Asia. We've all read his articles on multiple issues in dentistry. And he's also the technical head of the ICPA health products. So his career spreads far and wide from research to actual clinical dentistry. And with great excitement, joy, and pride, let me welcome our much awaited guest for today, Dr. Rajeev Chitguppi. Welcome to our session today, sir.
Hello, Dr. Diksha. It's my pleasure to be here with you in this session.
Great. It's a pleasure having you, and
I've seen some of your sessions very well conducted, and you ask the right questions and you get the right answers.
Thank you. Thank you. We've just been very passionate about this topic because I've never seen our fraternity go through this kind of a setback. So it's only fitting that we all do what we can to get us back to work and get us to safety.
Yeah.
Right. So, Doctor, I always ask this question to everybody who's on our speaker panel that how have the last 6 months been for you? And, what led you to become such a beacon of light for everybody in terms of all the research that you have created?
If we look at the date, today's date, I think we are in the third week of September,
Yes,
and the lockdown started in the third week of March. Like it has been a journey of 6 months now.
exactly.
And in the beginning, like everybody, I was also chilled out watching movies and having a good time on social media. But
Exactly.
being a periodontist, being a researcher, I used to follow literature, not as much as I do now. But that time when I was going through literature and then I was trying to find out what are the ways by which we can conquer the virus, how we can inactivate it, what are the different agents. And being a periodontist, my interest naturally went towards the mouthwashes. And one of the reports said that chlorhexidine doesn't work on SARS-CoV-2. I said, Chlorhexidine being the gold standard, being such an active agent and being so efficacious, effective against so many microorganisms, how
Yeah.
can it not be effective? So let me look at the susceptibility of the virus if there is any evidence. And when I looked into the evidence, I saw that all the microorganisms are put in a hierarchy, in a susceptibility matrix.
Right.
And in that, I realized that the bacterial spores for which we compulsorily need autoclave, come at the topmost level. They are very resistant.
Correct.
And then when I looked at where are the other bacteria, they came somewhere in between, much below the spores.
Correct.
And then I looked at where does a virus like SARS-CoV-2 come, an enveloped virus. And to my great surprise, I found it to be at the bottom of the susceptibility matrix. Means it is very susceptible. Then I wanted to check if it is so susceptible, how can chlorhexidine be not effective against this?
Right.
So that was my entry point. I started studying chlorhexidine,
Correct.
which took me towards the virus. One thing led me to another,
Yes.
virology, immunology. Then how about dentist practice? So it widened, the spectrum widened, and
Right.
here we are.
Right. And I think you've made rapid strides in a lot of information about not only testing, but also on, I think, dental aerosols, which have been a major issue for us in practice. And probably the biggest stigma of being at a dental practice right now is the fear of aerosols and the fact that they may carry the virus. So, what is your take currently on, safe practices with regards to dental aerosols?
The problem with dental aerosols started, it became a big issue in the
Right.
very early days, February, March, when that New York Times article came out, which said dentistry is the highest risk profession because
Correct.
dentists come very close to the patients. And not
Yeah.
only that, there are dental aerosol producing procedures. Okay. That time, our fraternity should have questioned, is there any evidence that dental aerosols really carry live virus or virions, which
Right.
actually went on to infect dental patients?
I
And
think
but
it was
the
an article which damaged the entire profession a lot without any scientific backing.
yeah, and a few interviews where leading authorities said that yes, dentistry is a high risk profession because of dental aerosols. Okay,
Right.
and so many guidelines started coming in, and dental aerosol procedures were a strict no-no for many months. It is very
Right.
recently that the articles have started coming out where they have started questioning the rationale behind
The
banning
claim. Correct.
aerosol procedures. Yeah, one of the articles that I've shared on Facebook was a very recent British Dental Journal article where they have said that the inclusion of dental aerosols came into picture because of a few studies done during SARS-CoV time in 2003.
Correct.
And even there were very few studies, retrospective studies. So even with weak evidence, grade 4 evidence, grade D evidence, they made a recommendation that dental aerosols are very dangerous. Okay, so I think we need to separate three things here. One is the aerosols that come out whenever a person is coughing, sneezing, or talking. That is one group of aerosols. Second
Right.
is medical procedure aerosols, which generate aerosols by direct manipulation of respiratory tract.
Got
And the
it.
third one is dental aerosols, where most of that content is the water that comes out of dental unit water line. Okay, so that should not be mixed with the other two. One is natural act of coughing, sneezing, and talking, and the second one is direct manipulation of respiratory tract during medical aerosol procedures.
Correct. Correct.
That's why, based on that only, I wrote a letter to the Health Ministry and ICMR that we are not, what you can say, we are not asking any irrelevant question. We just want to know if there is any valid evidence that shows that yes, dental procedure aerosols really contain live virus, and these particles actually went on to infect dental patients who were not exposed to the virus earlier.
Correct.
So if you show us that evidence, we'll follow you. Otherwise, you give us a statement that
Remediation.
we don't have an evidence. That's it. This is what I asked.
No, and that's correct. So, because I think there's so much of a fear factor that we are unable to differentiate scientifically that, aerosol originating from an infected patient versus aerosol which is coming from our water lines obviously has a very different capacity. And at the same time, because of not having enough time to document all of these things, it's just fear or anyone's first line of thought, which is becoming a mandate for all of us,
Yes.
which I think
Yes.
for years together will cause an impact for our community. Because when I went back to practice, I realized there's really nothing called a non aerosol procedure for us. Like, whatever form of dentistry you try, it's impossible to do it without some amount of aerosol. And,
Yes.
if you're going to fear that, then our quality of treatment is going to become, very substandard and people will keep coming back for treatments. So it's definitely not a solution unless we actually address the root cause which you have, which is to differentiate what type of aerosol and what is the actual evidence of infectivity.
Yes.
So I'm glad.
You define the risk. You define the risk. If you say it is really risky, tell us the high risk. If you say it is
Right.
not risky, let it be evidence based, not just notion based or you know.
Fear based. Exactly.
Yeah.
Exactly.
Yeah.
So I think what a lot of people couldn't do in terms of questioning, you have done. So I do look forward to the response now that we get. And even spreading this response to the population will be one of the responsibilities that we will end up shouldering to actually make patients realize that they are safe with us. So that will
Yes.
be, something that is a big task for the entire community. So, Doctor, I've read so much of your research about testing, and in fact, even I've, it was at the very initial stages my first line of thought that if I could test all my patients, I could go back to work, with minimal precautions if provided the test results are guaranteed. But there's still so much confusion about testing. I had even done a live with one of my pathologist friends, and even my mother-in-law is a eminent pathologist. So the conversations around the dinner table are always around testing. But when I
Yes.
read your work, I still find fresh new facts every time from article to article. And one of my major questions has always been antigen versus PCR, because the cost is so different that how do we go ahead and try and get antigen tests or trust PCR tests? If you could give me some clarity on this.
Yes. Antigen tests, actually, I had very little idea in the beginning. Even I was one
Right.
of those people who always felt RT-PCR is the gold standard and they should be followed.
Correct.
And then I realized RT-PCR has its own shortcomings. Like cost is high, and
Yes.
then it takes a lot of time. Like
Exactly.
if a person gets RT-PCR positive, and in which way that time we were not getting the CT value, the cycle threshold value,
Right.
which now we know that can change a lot in a very short span of time.
Correct.
So if a person who tested positive yesterday or negative yesterday, the status can change by tomorrow. Okay. So and RT-PCR being such a sensitive test, it goes on picking up even those minor amounts of genetic material from a person, that it tests even those people positive who went through the disease, recovered, and now they are all right. But even in those people, RT-PCR picks up those genetic material and shows them as positive.
Right.
Is
Right.
it relevant to us in dental practice? No. What is relevant to us is if a person walks in, whether he can spread the disease. So if we
Absolutely.
want, yeah, if we want to treat a patient, we just want to know if he's infectious. So here there is a clear-cut demarcation that is required. Infection is different, infectivity is different. A person
True.
may be infected, but he may not be infectious. He may not
Right.
spread the disease. So we just want to know who can spread the disease and keep him away. If he is not going to spread, take him inside. So which test can tell us exactly this point? Which test can tell me who is capable of spreading the disease? That is rapid antigen test. Rapid
Okay.
antigen tests are quick, they are not expensive, and they give you results very soon. Means what? If you have a patient today, you can get the result, you can get the testing done on the same day. It solves a lot of problems of dentists. So
Um,
when we are talking, yeah, tell me.
so these tests, do you recommend that the dentists do them themselves, like chairside with those, kits that come, or do you prefer that they're still doing it through another body, a testing body?
Right now, those tests are neither available for dentists to be done in their clinics, nor are they
Right.
available in the private pathology labs. They are only available at the government facilities and COVID centers.
Got it.
So the most practical thing would be to send, and they are all swab based. They are all swab based.
Correct.
So the best thing would be to send your patient on the same day to the COVID center or a government facility, get the test done, and keep your dental, confirm your dental appointment based on the results. Like if he is positive, then don't keep any appointment for him, because antigen tests have very high specificity. If somebody is antigen positive, it means he is as good as RT-PCR positive.
Got it.
Okay, so antigen positive means he is infected plus he is infectious. Whereas if a person is antigen negative, he still needs RT-PCR test to check if he is infected. But that is
Right.
not our concern. Our concern is if he is infectious. So if he is antigen test negative, you can be sure that he will not spread the disease. You can take him for your procedure.
So you
So
were
this
saying
is,
without the antigen, he is not infectious anymore.
yes,
So
check
the
the antigen test.
anti-infectious agent that is getting transmitted.
Yes, the viral protein that it identifies, that
Yeah.
defines the infectivity of a person, whether he can spread. So if antigen test is positive, because of its high specificity, you can trust it. So you need not treat that patient. Whereas if a person is antigen test negative, you can take him for the treatment. Now coming to who can do the test, if the dentist can do the test in the clinics, I think it will become very, very user friendly once we have saliva based antigen tests. As of now, we have all swab based tests. So either they have to train the dentist to take the swabs in the right way, or
Right.
the dentist have to send the patient to the facilities, government facilities, get the test done, and based on the report, take the next course of action.
Got it. And how easy is this government testing? Because sometimes they patients end up being a little resistant to go for tests at government facilities because of the crowd, or
Yes.
the risk involved. So is this a easy, smooth procedure? Would you have any idea?
As far as what I have heard from my friends and seeing at the discussion, looking at the discussion,
Right.
a lot of dental patients are hesitant to go to a government facility just to check if they are, because they are fear, no, they are scared if they can contract the disease there when they are there. So I
Exactly.
think this
Exactly.
is one point which we have to overcome. I think when we get very economical, quick saliva based antigen tests in the clinics, which dentists can do themselves, this problem can be solved.
Absolutely. So at this point, what is the current status of saliva-based tests? Like I read about an Abbott test on saliva. Is that something that you think would, if you can explain how that test works, or if you have any information on saliva-based tests which are ready to be available in the near future?
Yeah, the thing is, saliva tests, saliva is a rich source of virus,
Right.
and it is not new that we have started testing saliva. Saliva testing is a validated and approved test, but the sensitivity is not as much as a
Exactly.
swab test. That's why uh, a few months ago, saliva tests were reserved for only those situations where the resources were low. So if the person is not trained enough to take swabs, they can test from saliva. But right now, the sensitivity of saliva tests has improved quite a lot in the last few months. So we can trust saliva based tests also. So they will give you as accurate results as an RT-PCR would. So there are
Any
different, yeah, there
sorry.
are
Any,
different companies which are coming up with saliva-based tests. For example, there is Prakash Labs, which is coming up with saliva-based test. It costs less than $1 per reaction. Okay, very, very economical. You don't need any expensive equipment, and you will not need electricity also. I think it's a pH based colorimetric test. It just shows change in the color, and that tells you
Right.
that the person is infected or not.
Got it.
So
And
this is an alternate to RT-PCR itself. This is an
got it.
alternate to it's not an alternative to antigen test, but it's an alternative to RT-PCR only. So
So
my suggestion is till these high sensitivity tests like saliva tests come, you can continue with the available antigen tests.
right.
And once they come, you can keep a kit in your own clinic and you can do them. You can do them yourself because you don't need an expensive kit for that. They're very, very simple reactions.
Right. And in terms of saliva test, they are testing the antigen or they are testing a similar of the genetic material of the virus. What is the
Gen-
component?
Yeah, that's what I said. They are an alternative to RT-PCR. So they are testing the nucleic
Genetic
acid, the
material.
genetic material.
Got it. And the only problem with like, so there's a big myth, or maybe that's one other side of the theory, is that the concentration of virions in the throat is far more as compared to the saliva. So obviously the test needs to be that much more, quick, or like can detect the virus even in very low concentrations in the saliva. Would that be a fact, or is that just again a notional theory?
Mm, No, no, no. Initially, if you compare with nasopharyngeal swab,
Yes,
the viral load in the nasopharynx will be maybe much higher. But some experiments have shown that many experiments have shown that even oropharynx contains from oropharynx the viral load comes into the saliva. Plus, salivary glands keep on shedding virus into the saliva. So the saliva is all the time flooded with the virus. So you can always
got
trust saliva as a good source. What you can say, a reliable alternative to RT-PCR now, for swab-based PCR now.
got it. And so recently there has been some research from the Tata Labs also on one more form of testing, and I think they are testing the CRISPR. They're
Yes.
using the CRISPR technology, or that basic fundamental behind testing. So how do you explain this test different from the others, and what are your views on it?
So this is a genome editing tool. CRISPR is a genome editing tool. So Tata, in collaboration with CSIR, they have come up with this kit which you
Right.
can use for swab as well as for saliva. Both you can use.
Okay.
So it is called as Feluda, and the cost is going to be less than 1,000 rupees. So I think it is going to be very useful. So
Got
the days of being dependent solely on expensive delayed RT-PCR are gone. In the
it.
next
Right.
very few months, we will have three options: either to go for the traditional antigen tests, that will tell you if a person is infectious or not, or you will go for something like uh, simple saliva-based RT-PCR test, colorimetric test, not the typical RT-PCR test, colorimetric test, whether it will tell you whether the person is positive or not. Third is
Yes.
CRISPR-based test. So in the
Got
next 3-4 months, I think before the end of December, we should have a lot of much more user-friendly point of care tests, which will be very user-friendly for professionals like dental clinicians.
Got it. So I think even if we can come up with one method of testing which is working for our practices, out of these
Yeah.
three, whichever, like our patients have to be counseled enough to be, at least validating one form of test or the other. So if they don't
Yes.
want to visit a government facility, then they should probably try and pay for the PCR, or then as soon as saliva-based tests come in, we can start working with them to really protect ourselves, because we've all realized that the disease is going to stay with us and the vaccine will also possibly take a lot more time. So I think in the
Yes.
interim, we have accurate testing, and at the same time, while we're buying time for the vaccine, at least we're staying safe and limiting the spread even in the dental office. So
Yeah,
I
this
think
point
that's
is very relevant because a high sensitive test was required in the initial phase of the pandemic when it began.
right.
Now we
Right.
are in the middle of the pandemic. There are so many patients. Now we cannot afford to have delays, a lot of cost. We want quick results which are reliable and that can tell who can spread, who is infectious, For that, these three things. One is plain antigen test. Second is
Yeah,
saliva-based RT-PCR alternatives. Third is a test like Feluda, CRISPR-based technology. I think they are going to be game changers.
fair
So we have
enough.
to just wait and watch. It's a matter of few more weeks or months.
Right. And so some pathology labs also must be doing antigen tests. So if our patients don't end up going to government facilities, then we can send them to these centers.
I called up a few private pathology labs and they
Yeah.
said that they are not allowed to carry out these tests anymore.
Oh, okay. That's the latest.
Yes, so that's why one of the points that I wrote in my letter was that only either you give clear-cut instructions to the dentists where to get these tests done, or you
Exactly.
allow these tests available in the private pathology labs who will do the tests based on a prescription from a dentist. Dentist gives a prescription that please do this test in my patient, and they can do and give the report. Then it becomes very very easy for us.
Yes, and there's a particular reason why we're asking for this, and it makes sense if there are so many tests, then we should avail of the right test in the shortest period of time. Not
Yeah, and it was 450 rupees, less than 500 rupees. I think it is very very affordable.
exactly, yeah. So, I mean, in fact, a lot of dentists keep asking these questions on our groups or on Facebook or on various mediums and platforms because everyone's so confused what they should do in terms of testing. So, I think this would give a lot of clarity, and in the next few weeks and months to come, I'm sure testing before treatment will become a mandatory thing.
Yes,
So,
yes.
so, um, so coming back to your starting point of getting into research, I wanted to ask you what are those pre-procedural things that a person should follow before taking the patient onto the chair? Like chlorhexidine was one of the recommended protocols. So if you could compare for me chlorhexidine or hydrogen peroxide or even the role of any pre-procedural mouth rinse in actually bringing down the viral load. A lot of people talk about betadine, and they think any mouth rinse is effective to reduce the virus or the load in the throat. So if you could tell us what exactly, which agent and to what concentration will help us actually get the results that we want on the chair.
Okay. So first we have to identify. First we have to understand why are we using pre-procedural mouth rinses.
Yes,
Here the idea is not to cure the patient, but to protect ourselves from the spread.
exactly.
Now, if we are considering that dental aerosols that are coming from the from the saliva of that patient, we need to take all the precautions to minimize the spread. So how are we using it? Now, if we have to reduce the viral load, we need an agent which not only reduces the viral load at one moment, but keeps it low for a long period of time.
Right.
Because the patient is going to be on the dental chair for at least 1 hour.
Absolutely.
And during that 1 hour, the salivary glands are going to shed a lot of virus into the saliva. So mouth is going to be flooded again and again with the virus. And not only
Right.
salivary glands, they are coming from your oropharynx also. So you
Correct.
need a mouthwash which is not just antiviral but also continues to stay inside the mouth for sufficiently long.
True.
So there are mouthwashes which you use, you rinse them as long as they are in the mouth, they kill the viruses, but they don't have any attachment mechanisms. What you need is persistent attachment and sustained release into saliva. This is called as substantivity.
Got it.
Now, if you look at the British Dental Journal 1999, since so many decades we have this evidence, it's not a new evidence, that mouthwashes are classified, they are grouped into those which have substantivity, that is long attachment and long release, and those that don't have this property.
Right.
And that classification shows that only chlorhexidine, which is considered as the gold standard in the perio domain, that is the only mouthwash that has got substantivity. Whereas when it comes to others, whether it is essential oil mouthwashes, povidone iodine, hydrogen peroxide, or chlorine dioxide, whatever it is, they may have antiviral activities, but they don't have substantivity. Means what? They will keep on killing the virus as long as a person is gargling them. The
Right.
moment he
Right.
spits them out, post gargle, there is no action. So if you
Got
want
it.
a chemical agent to continue to act even after you spit it out,
Yes.
that should have substantivity, and that is available with only chlorhexidine.
Okay. And
So this
two questions
substantivity.
here.
And then
Right.
the second point is if it is antiviral, if a mouthwash is if chlorhexidine is antiviral. So we know that in the beginning, the thing that brought me into this pandemic COVID research was a few reports that said that chlorhexidine may not be effective against SARS-CoV-2.
Right.
And when I went into the literature, I realized that in the early 1990s only they had shown chlorhexidine to be effective against enveloped viruses. You destroy the lipid envelope and the virus gets inactivated.
Right.
And then a few later experiments showed that chlorhexidine was not able to inactivate it. I said, how is it possible that a mouthwash that is so effective against all the microorganisms not be able to inactivate SARS-CoV-2? When I looked into the values, I realized that those experiments had used very low concentrations of chlorhexidine. Either it was 0.001 or 0.002. In that
Got it.
concentration, nothing works. And as we saw in the month of April, Hong Kong University Medical Division, they published a report in Lancet which said that uh, chlorhexidine mouthwash, chlorhexidine gluconate in a concentration as low as 0.05%.
Right.
0.05% is enough to inactivate the virus. And then a
Got
Korean study showed that if you use chlorhexidine mouthwash for 30 seconds, it keeps the virus away. It keeps the not the virus away. It reduces the viral load in the saliva for
Right.
2 hours, during which you can complete your dental procedure.
Great.
So that
So,
way,
yeah,
yeah,
0.05% for 30 seconds is what we
yeah,
recommend with deep throated gargles, is what we would
yeah,
want them
yeah,
to do.
yeah. But if you look at the currently available mouthwashes, we already have 0.2%, which is already
Exactly.
4 times more concentrated than that. So
Correct.
if you simply use the rule of 10, 20, 30, I'm making it very
Yeah.
simple for everybody. 10, 20, 30. Take 10 ml of 0.20% of chlorhexidine and rinse it for 30 seconds at least,
Great.
preferably undiluted. And now
Direct.
the article says it gives you a protective window of 2 hours. If you think you need more protection, ask the patient to repeat after 30 minutes. Big deal.
Fair enough. Yeah, it's
Uh,
a simple procedure, and if it's showing an evidence-based reduction, then why
yeah.
not?
Yeah, and
Absolutely.
if there are people who say that the guidelines say that you should use povidone iodine or hydrogen peroxide, what to
Yes.
do? Very simple, make use of both. You follow the guideline, use betadine, okay, or hydrogen peroxide. You have followed the guidelines. They have
Right.
reduced the viral load, existing viral load, and after
Yes.
that you give chlorhexidine mouthwash.
For substantivity.
For it continues to prevent the new virus coming down, and there is no problem with cross reactivity between chlorhexidine and povidone iodine, because there is no povidone iodine in the mouth at all to give any kind of adverse reaction, because once you have once it is
One.
out, it is over. Its action is over.
Exactly. Okay, great. So I think that's a great solution. And I like 10, 20, 30. That's something that we can remember easily. And
Yeah.
there was a lot of confusion with people when, conflicting products or guidelines or chemicals had to be used. And I think all patients would be happy to rinse multiple times and realize that our dentists are looking after us versus, just taking us in for procedures without any precautions. So I think this would be great to have two rinses with different mouthwashes if there's a conflict. Otherwise, I think chlorhexidine by itself
Good enough.
would be good
Good enough.
enough to go ahead. Right?
Yeah.
That's great. So it's myths like this that we want to address in this conversation. And I think another big myth in our community is that we all believe that at some point herd immunity is going to come and save us, and somehow all of this will disappear, and somehow we're all looking for a solution or some sort of treatment or vaccination. So we had touched upon this earlier when we were talking about testing, but I'd like you to give us a little more detail on what is your take on the status of vaccines. and the possible myths of herd immunity, or maybe a fact if you think it is.
Okay, when it comes to herd immunity, it can be achieved by two things, either by natural infections or by vaccinations.
Right.
If you look at the literature, herd immunity, the term herd immunity was used to guide the vaccination protocols. Now, there are two schools of thought. One is expose the people to natural infection, let them get infected, and they will develop herd immunity. Okay, and the same people say if you keep people locked down for too long,
Right.
you are delaying this herd immunity. So this is one school of thought. The other
Right.
school of thought says that vaccination is the only way,
Correct.
because classically the term herd immunity has been used for vaccinations. So these are two schools of thought, and both of them are very, very strong. They are very strong proponents of their own schools of thought. So
Right.
as of now, I only know that people who started the policy of exposing their population to through natural infection so that they develop herd immunity took the risk in the initial part, and those who kept people locked down for too long, they just
Right.
pushed the risk to a later period. So the risk is going to be there.
Correct.
So we need to develop strategies by which we can protect the vulnerable and expose the least risky people, and
True.
slowly develop herd immunity, and by which time hopefully we should get a vaccine which is not only very safe but also effective and gives you protective immunity.
Got it. But how practical, like, would it be? Like, you mean to say that continue to keep the older people with comorbidities locked down, and probably expose the younger working class, let them go about their lives, let them open up from lockdown and go ahead till a point where we can actually get vaccination, which is probably at least another year away, is the way I'm hearing things.
Yeah, see, vaccination with its own ups and downs. See, it's not an easy
Right.
procedure. It's not an easy process. It has its own challenges. So we cannot definitely say. Looking at the reports, it seems practical, reasonable that we may have a vaccine in the summer of 2021. Not for everybody, but
Some.
something
Right.
available in the market. But
Exactly.
when it comes to protecting the vulnerable and letting the fit ones get a herd
Get
immunity, all depends on very strong, very well established diagnostic tools like this. So if we come to know who is infective, okay, who can spread the disease, keep them away, all these things are interrelated to each other.
got
And
it.
as the time progresses, all these things will come into the market together only. So I think in a few months' time, we'll be much better positioned to come up with a policy on how to expose what kind of population for natural infection, what kind of test to be employed to check who is infected and who is infectious. And in a few months, we should have some vaccines also that can be given
Right.
first to the healthcare workers. I think in the last 6 months itself, we have had considerable progress, and in the next 6 months, we should be having a lot of definitive answers. So, as of now, I have some guess, some evidence-based guess, calculated guess right now, but I'm not be able to give you all the answers. I'm following the evidence as keenly as you are all doing.
Right, absolutely. So, I wanted to know, Doctor, the potential side effects of a vaccine. Like, what are your takes on that? Like, initially, of course, we want healthcare workers to take a vaccine, but because the process of building a vaccine this time has been so prematurely accelerated because of this being a pandemic of such proportions, what is your take on the risk factor of this vaccine?
If you look at the timeline of various vaccines developed, the earliest of them took hundreds of years. Then it came to tens, a decade or so. Now
Yes,
the timeline is shortening, and with the
very
kind of technology and the know-how that is available as of now, we shouldn't
right.
be surprised if we are able to develop a vaccine much faster than what we did before. But at the
Fair
same
enough.
time, the protocols are they have to be stringent, and we must expect that there are going to be one or two complications that may come, which will make the trials halt for some time, pause for some time, and that has happened because of transverse myelitis cases. And these are the things which led to a lot of public distrust, in the
Exactly.
trial. They wanted transparency, and at the same time, the number of people who refuse to take a vaccine, even if it becomes ready, that proportion of population is increasing. So the
Increasing,
companies
right?
had to become very, very transparent with their protocols. That's why in the last week we had all the three major players, Pfizer, AstraZeneca, and Moderna, releasing their
Results.
SOPs online. Yeah, so in
Right.
a bit to improve their trust factor and transparency. So far
Correct.
so good, and let us keep the faith alive and pray
Yes.
for the best.
Yes. So, coming to some other risk factors as well, I want to ask you if, like, when we get into practice or even when our patient comes in, certain individuals are exposed to certain risk factors. Not everyone's risk would be the same. So, what are those things we can do to mitigate this risk? Like, are there some factors we can actually help control, or you think everyone is at that same level of risk and we have to go ahead and sort of expose ourselves?
Thank you for asking this question, because it is one of my most researched areas. So let me
Right.
tell you that there are three risk factors on which we don't have any control. First, the first factor is there is something called as baseline inflammation that everybody develops with aging. Why are aged people more prone for the disease? Why are they more prone for developing complications? It is because as age advances, our immunity goes down, and the inflammatory status inside our body increases. So the baseline inflammation without any provocation,
Right.
baseline inflammation itself is high. So
Right.
as age advances, the pro-inflammatory status is very high. So aging is something we cannot control. So this is the
Correct.
first risk factor which we have no control over. Second risk factor is whether you already have pre-existing immunity, which might come to you from other coronaviruses, similar viruses, which could be common cold coronaviruses also, which we don't
Mm.
know. If we have people who have that are more protected. Okay, so here we should know that T cell. All this while we have been focusing only on antibodies, but when
Right.
it comes to immunity and protection, a lot of research is going on the T cell based immunity, the cell mediated immunity. Okay,
Right.
so I think we should develop more and more tools by which we are able to measure the T cell imparted immunity. So this is the second risk factor. If we have that, it is good. And the third risk factor is people who have genetic susceptibility to different comorbidities. Like some people have very high susceptibility in the family for hypertension, cardiovascular diseases, or diabetes. So this
Right.
genetic predisposition you cannot change, but you can modify it through your lifestyle. So three
Exactly.
factors which you have no control over are baseline inflammation, pre-existing immunity, and your genetic predisposition to different systemic conditions. Then you have got two risk factors on which you have full control. You have full control over these two factors, which are
Hmm.
those obesity and vitamin D levels.
Right.
The evidence has shown that people who are obese have developed more complications, and even the mortality rate is high in them. Okay,
Right.
again it comes back to the same thing. Obese people have got higher pro-inflammatory status inside the body. So if you
Right.
can control your obesity, or if you are overweight, if you can reduce your weight, it is very good. And the second one is vitamin D levels. If your vitamin D levels are low, you better improve it, because people have found a direct connection between vitamin D levels and the risk of COVID-19. So these are
Yes.
two risk factors: vitamin D levels and obesity. So I think in these five factors, a lot of things can be put.
Not control. Right.
So
So
three you
out
don't have control, two you have control over.
Great. But out of all of them, Doc, the way I see it is that baseline inflammation should be low. So it's
Yes.
inversely proportional that way. And
Yeah. That's why,
predisposing,
that's why they have postulated that any drugs that reduce your pro-inflammatory status may help the condition. They will reduce the risk. For example, MAPK inhibitors. You can add melatonin to this. You can add steroid to this. So they can
right,
reduce your pro-inflammatory status in the body.
right. And pro-inflammatory status will also be something like, how when your biological age is
Yes.
lesser than your actual age, right? Like when you're fit,
Yes.
you tend to measure that also, that biologically I'm younger than what I should be. So that's, I think that's
Yes.
a good measure or marker. So I guess
Yeah.
fit people will be less susceptible. More people with more comorbidities would be more susceptible. And
Yeah.
any test that we can do to measure T cell immunity,
Direct measurement may not be enough, may not be feasible as of now.
right?
I'm not sure whether we have established tests, but they have started developing surrogate markers. Like they don't have true markers, they are developing surrogate markers. I think we should also have tests for that. But as of now, we already have two very good tests in our hand. Get a blood test done and check your vitamin D levels in the body.
Right.
If they are less than 20 nanograms per ml, you better get a vitamin D shot and check your body mass index, BMI. And if you
Yeah.
are overweight or obese, bring down your weight.
Right. And on that same note, doctor, what are your thoughts on zinc as a supplement? What kind of research have you read for zinc as compared to vitamin D3? Because I think that's the other supplement that's being overprescribed.
Yeah, yeah, yeah. Vitamin D, vitamin C, and zinc, all three have been prescribed.
Right.
People have been taking. So zinc, I think, has been tested in both ways. One as a preventive tool,
Right.
as a preventive regimen, and second is in combination with hydroxychloroquine, azithromycin, and zinc
Right.
for pre-exposure prophylaxis as well as post-exposure prophylaxis. This is how zinc has been there, but I don't know whether there are studies which have focused exclusively on zinc and checked that by adding just zinc, removing all other confounding factors, if it has really helped. I think
Great.
even I have to read more on that.
Yes. So, as you're mentioning, so that out of all of these things, like these risk factors, we can control, and like in the long term, we may want to get fit, but in the short term, we know we're living with the disease, and sometimes overnight, people are ending up with symptoms. I hear a lot of people who are ending up with symptoms even when they've been just home and they're not able to trace how exactly they got infected. But let's say if we do get infected, either in the line of duty at our clinics or as healthcare workers, or even a loved one gets starts showing symptoms, there has to be a recommended protocol in which we go ahead and deal with this, depending on the severity of the symptoms, right? So, if you could tell us, like, what are those things that, despite taking all these precautions and studying all this and knowing the disease so well, if somebody with us or even a patient starts presenting symptoms, what should be our action steps be?
Yeah, very relevant question. We should know that there are two things. One is infection, second one is disease. A person who develops infection may not develop the disease. Who gets infected may not develop the disease. And at the same time, a person may show symptoms, may not show symptoms. And symptoms
Exactly.
can be vague, they can be specific. That's why, to come out of this dilemma, instead of focusing on the symptoms, we should focus on signs. The signs and symptoms, that signs we have to focus on.
Right.
So, if a person has got any vague symptoms, any mild symptoms, first thing is don't ignore the symptoms.
Right.
Don't jump to treatment directly. For example, let us take paracetamol. Okay, let us take azithromycin. You may take them to reduce your symptoms. At the same time, you look at the signs. Symptoms may change, but the signs don't change. So, what are the signs you need to look at? For this, I have developed a simple protocol called as ABC protocol. Very easy to remember. It is easy to remember for general public as well. So for doctors, it is very very easy, and many doctors know much more than this ABC protocol. It's a very very basic protocol. So the thing is, A stands for air. Air is oxygen.
Okay.
So if anybody you know has developed vague symptoms, take them seriously and ask them to start measuring their SpO2, that is oxygen levels,
Right.
using a pulse oximeter. Okay,
Correct.
so walk for some time, 5 to 6 minutes, and put the pulse oximeter on the middle finger of your dominant hand. If you're a right hand user, use it on the right middle finger. If you're a left-handed person, use it on the middle finger of your left hand, and look for the
Right.
values. Ideally, it should be above 95, and they should not go below 94.
Got it.
And pulse oximeter is one thing which is a monitoring tool. So whatever number you get in the first test is not the only number, because many people have lower numbers but they are stable at that level only.
Right.
So when pulse oximeter becomes reliable is if the number falls below 94 and starts going downwards, starts moving and reaching 90. Don't allow it to reach 90, because 88 to 90 or 89 is the critical level. So on
Right.
checking pulse oximeter daily, if you find that the number is gradually lowering, going towards 90, then out of ABC, A is tick mark now.
Right.
Don't wait any further. Jump to B. What is B? B stands for blood.
So one question here: when
Yeah.
taking the pulse oximeter reading, are you taking averages, or do you take only the first reading and take that as the reading for the day?
I suggest if somebody has developed symptoms, he should take the average value of the day. So
Correct.
you can take one reading in the morning, one reading in the afternoon, one reading in the night, but every time after doing a walk, then you
Yeah.
take the average of that one day.
Got it.
Like that, you start taking the average of each day, and if the graph shows that the average values are going towards 90, be alert. Okay, then jump to test B. B is blood, simple blood test. Get complete blood count or CBC. And in CBC, what you should look for? You should look for the lymphocyte count.
Right.
COVID-19 is known as a serial lymphocyte killer.
Right.
Lymphocyte count should be between 20 to 40%. And if your blood test shows that lymphocyte count has fallen below 20, it means what? You should suspect that person of having COVID-19. Now, if
Correct.
lymphocyte count has gone below 20, look at the neutrophil count. If the neutrophil count has increased 4 times more than the lymphocyte count, that is, if neutrophil lymphocyte ratio is more than 4, the suspicion should be even stronger.
Got
Okay,
it.
so if you find that the oxygen levels are going down towards 90, lymphocytes are lower than 20%, and neutrophil lymphocyte ratio is more than 4, then jump to C. A, B, C. C is chest or high resolution CT
X-ray.
scan of chest.
Okay. CT scan.
Look
Okay.
for ground glass opacities. Okay, and they will also give you something called as CORAD score. So CORAD score can be correlated with RT-PCR. So higher the CORAD score, higher chances of it being it if it reflecting the RT-PCR value. So there itself you come to know that if the person is severely infected. So the symptoms might be mild, but inside the disease could be growing faster, which you can detect by following the signs. So COVID has shown in the last 6 months that there is one critical rule of preventing complications and preventing deaths. What is that? Detect the disease early. The earlier, the better.
Got
Those who got it detected early responded very well. If detected early, all medicines will work. You need very few medicines. Detect late, the delay causes all the complications. Greater the delay, greater the complications. So just use ABC for early detection and save lives. This is my ABC protocol. This I published on my ResearchGate also. You can go follow me on my ResearchGate. Okay.
it. Right.
So on ResearchGate, I have put the full article. You can download the PDF, and it is very very easy. You can, and I'm trying to get some animated videos also in the next few days. And if whenever these videos come, I'll be putting them on my Facebook profile. So people can follow me on my Facebook, and whatever I read, I share with everybody on my Facebook. So people can share me, follow me on Facebook. So this was
Great.
ABC protocol. I think it sounds easy.
Yes, sounds very easy, and at the same time is very, very informative because you have an action step for each, sort of attack point of the disease. And I think with the ABC protocol, we are also not just subject to waiting for test results, which we normally do. We based
Very, very
very,
important. This is exactly, yes. Yeah,
yes,
very. What that is the point which that sent me, which made me to come up with this protocol. The moment you have got ABC independently tested on your own without undergoing RT-PCR test, if your CT scan shows that your lungs are involved, you can directly seek medical help, and they will directly put you on oxygen, Dexa, and heparin as the need be. And the earlier these interventions are started, you will be in a much better position.
exactly. And these are the things that even the common man should be aware of, only because instead of waiting with the fear that do I have the disease or not, or even a loved one is unable to do anything for their family till they don't get the report. Instead,
Yes,
you've given some actual constructive action points, especially because the pathology of the disease sets in, like every day is critical for us to take some or the other action steps, and as we get more and more confirmation we can take the necessary corrective measures. So I think this has
yes.
been very, very informative overall, doctor.
Yeah, in fact, ABC protocol is something that I have been educating people about. A lot of people have already applied it, and already a lot of lives have been saved because of ABC protocol. So that's why I'm taking it into the population, into the public as much as possible. So people should take help of it.
Great. I think this has been such an informative talk. As promised, we have covered so many topics which have been really confusing and needed a lot of clarification. So I think you have done true justice to the topic of today, that we've actually sorted confusions and created clarifications. I'm sure we'll hear many questions from the audience, and I would send them your details so that they can stay in touch with you and become actual like providers of care and prevention, because I think that's our responsibility as healthcare workers, to not only just worry about our own practices but also make sure that we are mouthpieces for prevention of the disease. So just like you have, we hope to make the same kind of foray into prevention. so I think with this talk many will be inspired to help their patients, help their families, help their loved ones. Thank you so, so much, doctor. It's been very, very,
Had
thank
a
you so
great
much.
session with you. Thank you so much.
Yes, thank you. So that was Dr. Rajeev Chitguppi, the legendary Dr. Chitguppi, who's always talking about new things for our community and doing all the research and legwork so that we can go back to our practices without even having to read so many resources. So do follow him on Facebook and ensure that you also sign up on his research kit so that you stay aware of the latest protocols in terms of prevention of COVID as well as detection and timely treatment. We can't live in the fallacy that we will not have this disease around us for the foreseeable future. So we must start learning to adapt to live with the disease in the best possible way, and also safeguard our patients as our own moral responsibility. So I hope, like most of our sessions, this has been of extreme value to you as a dentist or even as a layman who's watching this. And we do hope to bring you many more such informative sessions. Thank you so much for joining us today, and do post your questions in the comment box below. You will definitely be hearing from us and Dr. Chitguppi on the answers that matter the most to you. So thank you once again and see you next Sunday.